Hi, my name is Dr. Philip Wrotslavsky from the Advanced Foot and Ankle Center of San Diego, and welcome to The Fix. Today we are very excited to have joining with us Dr. Lisa Grant from Virginia Beach, Virginia. Welcome.
Thank you so much for having me.
You brought a very interesting case to share with us today. Please tell us a little bit about it.
So I had a woman that had been in and out of the emergency department for complaints of swelling, and she had multiple diagnoses, cellulitis, DVT. She finally went to see a foot and ankle specialist local to her area, and they sent her to my office for surgical consultation after identifying a fracture dislocation of her Lisfranc joint.
And these fracture dislocations, if left alone, could become a wound, infected, and lose their leg.
Correct.
So when you look at these patients and they come in the office, tell us a little bit about how you analyze the deformity and the next steps about picking the hardware that you're going to use to correct the deformity.
Sure. So in this particular case, obviously we obtained 3 views of the patient's foot and identified that she had a dorsal subluxation of the metatarsal of about 4 centimeters or so. Her cuboid was also subluxed, and so she had a lot of instability at the level of the CC joint. And we recognized that in order to get this appropriately aligned, we really need to be able to distract that out to length so that the bones can kind of reestablish an appropriate meres and alignment, essentially. So,
and this is also a multiplanar deformity.
Correct. Hindfoot was in neutrality, essentially on this. She had a little bit of equinus deformity, but not a ton to the hindfoot. It was truly a deformity located at Lisfranc's. But she did have a little bit of elevatus of the first ray and some stacking that needed to be addressed as well.
So you had axial, rotational, and translational issues
Correct.
to deal with.
Correct.
So you use those principles to, when you talk to the patient, to explain to that patient, this is your deformity and this is how we're going to correct it. So you chose to do gradual deformity correction in a planned 2-stage procedure. Mm-hmm. So stage 1 of the planning is how do you decide what you're going to use and to address that through gradual correction?
I think it depends on the deformity itself, on what I choose. There's 2 primary workhorses associated with forefoot and hindfoot deformity. In this particular case, because of the neutral hindfoot, we chose to utilize a Hexapod butt frame. I utilized the Hexapod system as opposed to the Truss system because there was more deformity to address. It wasn't straight linear distraction. That's easier for the patient to kind of handle and to do themselves and to train the person to do that. In this particular case, I needed to dial into pronation. I needed to distract. And so because there was, and translate, because there was multiple stages in the deformity correction, having this automated and prescription-based product the patient can kind of turn on their own is actually kind of a better method.
So you use the TL HEX, and the patient's given a formula on how to turn, which struts to turn what day, correct?
Correct.
So tell us how that went and what you were trying to accomplish with the strut turning and the distraction.
So in the plan for this deformity correction, we were really trying to distract and then translate the segment down and then rotate the first ray. And so in this particular case, we gave this very automated prescription. The patient's family was more than capable of turning it. She would come in weekly to just make sure that the pin care was appropriate and that she was looking good. And then we were getting closer to the time that infix, and the closer we got to that time frame, I was like, okay, well, everything looks great. I'm really satisfied with the final result, and we're ready for infix, but do me a favor and just slightly distract. And I gave them 2 clicks a day and just pure distraction. And they went a little overboard with it. And that's okay, because the end result was that it was really hypermobile in the OR, and it actually made the deformity correction even better. And so it was kind of a nice turn of events, and something that I probably will use in the future too. Over-distraction is a good thing in this situation.
So then you take off the frame in the operating room. What was the next step?
So the next step, once the frame was completely removed, the correction of the deformity, it came together just on its own. Like after the removal of the hexapod, the deformity was pretty much where it needed to be. It looked like a neutral alignment. And so I only really needed to just do a little bit of a tenaculum lift up to that ray and just kind of squeeze the cuneiforms together, because the hexapod can't adjust for that, essentially. And so all I did was just kind of bring the cuneiforms closer together and then ran the beams.
Tell us a little bit about the beams, and you use the G-beam, correct?
I do. I use G-beam, and I do that because I feel that the product was designed specifically for the deformity itself. They utilized the appropriate materials and the appropriate caliber screw or diameter of screw that can really resist like 300 pounds of force that's being seen at the TN joint. And so unlike kind of some of the other products, I feel that this was actually designed specifically for Charcot.
And the G-beam, as we know, is made from surgical stainless steel, so you can't bend that.
That's correct.
But we've seen cases of titanium beams that bend.
That's right.
So you also use a very interesting technique that's well known and well accepted called the trussing technique as well.
Yeah.
So besides beaming, you're adding a truss, and you're using G-beams to truss. How does that work exactly?
Yeah, so once I've established the appropriate correction to the medial column, the lateral column, and the subtalar joint, what we see is, if you correct the deformity, and then you correct the deformity to the lateral column, and then you fuse the subtalar joint, that's technically supposed to lock the column. However, after a period of time, reoccurrence were seen. And that's just probably the nature of the dynamics of the two columns and the level of the midfoot. And so a beam can actually be applied at the base of the second metatarsal into the anterior process, the calcaneus, to actually unite the medial and lateral column, which is suggested to kind of produce like more robust or long-lasting result. And so I do routinely add a truss to my Charcot reconstruction, and I have seen more positive, less reoccurrence, and more positive results associated with it.
I agree with that technique as well. I do that myself. How did the patient do in the end?
She did really well. She is she's lovely. She tends to come in the most inappropriate shoe gear, which I think is just a testament to like the strength of the beam. So she'll come in like wearing Teva flip-flops, and I'm like pulling my hair out, just like begging her, like, please wear your device, like stop wearing these low profile shoes. But no issues so far. So
that's fantastic.
Yeah.
Thank you for sharing that case with us.
Absolutely.
And thank you for joining us today on The Fix.